Thanks. So we'll move on to Dr. Aditya Daftary now. And I would, so thanks, Dr. Aditya. I would just like to introduce Dr. Aditya Daftary. He's basically board certified MSK radiologist from the American Board of Radiology and has done a fellowship in MS musculoskeletal radiology from the Hospital of Special Surgery in New York. And he has quite a big experience of MSK radiology. So, and he has, we have had the privilege of learning from him about MRI of foot and ankle last year in a webinar. So thank you, Dr. Daftary, for being here with us. And I'd like to invite you to start your talk. Thank you.
Thank you. Thanks, Maninder. And thank you, everybody at IFAS for having me here. So I'll just go ahead and get started with things straight off the bat. So the talk is on ankle CT, when and why. And I think I'm hoping everybody can see my screen and hear me. So I think the broad overview is when would you consider a CT? Why would you do it? What would you expect to find? And how would that change what you are going to do? And I think this is valid not just for CT, but for any examination. Whether you're doing an X-ray, an ultrasound, an MRI, the question is, why are you doing the study? And I think the most important thing in all of this is you should be prepared for you should be prepared for whatever answer comes back. In other words, you come back with something saying that you don't have an answer to in terms of what you want to do with it, that really doesn't help you. So remember that whenever you're doing a test, you're trying to get, what the answers are going to be, and how you're going to react to each of those answers. So I think that is probably the most important thing of most of these imaging tests and any other test that one does. So what I've done is I've gone ahead and created 6 situations in which I believe that CT has a role to play. And I'm going to go through them systematically. So the first one is the situation of an ankle sprain, which is something that we all see routinely. And in an ankle sprain, we end up looking at a normal X-ray. And usually you end up with a normal X-ray, but the patient comes back to you with persistent pain and swelling. Now, typically these patients would go down the path of getting an MRI. But sometimes you may not have it available, or you may end up getting a CT, or the MRI is not really giving you all the things that explain why the person has a problem, in which case you might consider doing a CT. And what would you expect to find on this? So typically what you end up seeing is fairly subtle fractures. So like in this case, you can see an anterior process calcaneal fracture, or you can see a nutcracker fracture, which involves the cuboid and the navicular because of crushing between of the cuboid between the metatarsals as well as the navicular. And then this, because of the way that crushing injury happens, it alerts you to the possibility of a posterior tibial tendon injury. So I think the thing that really needs to be driven over here is that on patients who have a so-called normal radiograph, we can identify subtle non-displaced fractures. While many of these fractures do not need surgery, they do explain somebody's persistent symptoms. They provide a great way of reassuring the patient as well as the surgeon that nothing else needs to be done. They help you to explain or understand injury mechanisms. How did the patient get injured? What was the injury that happened? It initiates the search for more grave injuries. So if you saw a subtle avulsion injury, say, for example, involving the syndesmosis, then you might say, oh, wait, this is not a routine ankle sprain. This is something that is probably a high ankle sprain and needs to be managed more aggressively than we at first thought. And one thing just to warn you, a lot of people get MRIs that are done that the quality may not be great. And these fractures, as you can see, are fairly subtle and small. Sometimes the fat suppression is not great, especially for a peripheral joint like the ankle. So you can miss these fractures very easily on an MRI. And therefore, in that sense, CT can have an important role to play in these situations. So this is the first situation. Now, the second situation is you have a person who you look at the X-ray and you see that there are fractures. They're very obvious fractures to you. And why would you consider a CT in those situations? So let's take a look at this example of a patient who has a young child who has a fracture that goes through the distal tibial epiphysis. And when we look at this fracture, the question is, what runs through our head? And the first thing that runs through our head is this a juvenile Tillow fracture, or is this a triplane fracture? And we sort of see this line running up the back, and we see this thing here, and we're not really entirely convinced into which category it falls. So in that case, a CT is really helpful because on the CT, you would see very clearly that this is a triplane fracture, or you'd be able to differentiate very clearly in a different patient that this is a juvenile Tilo fracture. So in other words, you see a fracture, but you want to reconfirm that the fracture that you're seeing is exactly the same fracture pattern that you think it is, or you want to clarify your doubt on what kind of fracture you're dealing with. And potentially that clarification would lead to an altered management for that patient. The second thing that you want to do, somebody's got an obvious bimalleolar fracture in this case, is did you miss something that would change management? And most typically, you end up missing posterior malleolar fractures. These are difficult to see on an X-ray. Sometimes if they're small, if they're non-displaced. So that's difficult to see. And then sometimes you may miss something along the anterior distal tibial articular surface, like a Chaput fracture. So there's data obviously from our own country, which talks about how we have a decent number of missed fractures on X-rays that can change management. So they said in almost 23% of cases, the management plan changed after a CT evaluation. Most of the time, it changed because there was a malleolar injury, most likely posterior malleolar injury, and the fracture wasn't identified. And Chaput fractures are easily missed on radiographs. So, I think, did you miss something that could alter your management would be another reason to consider getting a CT. The third reason that you'd want to get a CT done is you see an obvious fracture again, and you want to know more about this fracture. You can't characterize it as well as you could on the radiograph or as convincingly as you would like on the radiograph. And in that case, a CT helps you to divide something into whether it's a tongue type or a joint depression type. You can look at the coronal CT sections and you can determine which Sanders classification or any other classification that you're comfortable with using. It gives you a clearer idea of the geometry of the fracture, and it gives you a better understanding of how you could potentially approach treating this fracture. Another important thing that CT can tell you at times is it can show you that fracture fragments are impinging against soft tissue structures. So for example, here's a patient who has a calcaneal fracture, and you can see the calcaneal fracture fragment impinging against the peroneal tendon running across adjacent to it. So this does give you a sense of not just the fracture itself, the fracture geometry, as well as impingement upon adjacent structures. When you have, again, fractures that are like this, that extend intra-articularly, it gives you a much better understanding of the intra-articular extension, the step off, and then potentially this would have a role to play in terms of how you decide to manage this, especially today, in today's day and age, with more and more people looking at arthroscopic techniques and looking at open techniques and mini open techniques. I think having a clearer understanding of what the fracture is, what structures are involved, is particularly important in helping you to decide what kind of management course that you would take. So it can give you more precise, measurable offsets, articular surface gaps. And in today's day and age, you can also get 3D modeling done, which can allow you to actually play with those fracture fragments and everything in real life before you do surgery to help you to do the best possible thing for the patient. So why CT and acute fracture? You want to confirm it is what you think it is. You're not 100% sure where it falls. You want to confirm that. You want to ensure that you don't miss a management altering injury. So if there's a subtle fracture somewhere that indicates a different kind of injury, or you want to size up a fragment that you could potentially fix, then that's particularly important. You want to classify the fracture or the injury appropriately so that you can manage it by operative technique appropriately. So you want to know the fracture geometry, the articular involvement, potentially get 3D modeling done to help you to understand how to manage that fracture, what technical considerations you would involve in fixing that. And then I think the last but not least, subtle fractures are missed easily on poorly performed MRIs. And that's why actually many centers do limited CT. Oftentimes as radiologists, we hide those CTs from you because we just do it for our own understanding and so that we don't miss anything. So if somebody's done that, make sure you know about it and you take a look at that. The third situation I'm going to talk about is soft tissue injury. And that is a person who has a soft tissue injury or who had a soft tissue injury, ligamentous injury, let's say, and now has chronic pain. And in these cases, CT plays an important role for a few different reasons. So the first thing is somebody had what you felt was an ankle sprain, but they continue with, to come back to you with continued pain. And in that case, a CT is helpful because it might be able to, you can compare both sides simultaneously. You can see that there's widening of this syndesmosis on the symptomatic side as compared to the asymptomatic side. And then along with that widening, you can see that there's this little posterior avulsion along the posterior aspect of the posterior malleolus. So this would be something that would be a missed syndesmotic injury. So you missed an injury that you hadn't seen before, and CT would show this. On MRI, this could be a challenge because these ligaments may be continuous, they may look stretched, but you wouldn't have a sense of the laxity of those ligaments if you just looked at this and you didn't have the comparison with the opposite side. Now, you might have picked that up on X-ray, but nevertheless, CT can show you this as well. So I think CT is kind of important. When you look at the CT, when you see an injury pattern, you know the fractures, make sure you know what injuries could be missed to look for those subtle widenings and subtle fractures that could say that you missed a particular injury. The second thing that happens in people who get ankle sprains, especially, and in other injuries, is they get talar osteochondral lesions. Now, as orthopedic surgeons, oftentimes one is not entirely sure what this means. So on this X-ray, you can see this just looks like a subtle undulation of bone here. Nobody has a sense for how bad this osteochondral lesion is, how big it is, or how problematic it could be. You look at the MR, and as radiologists, we're very excited. We see subchondral cystic change, we see cartilage loss, we make all these wonderful descriptions. We say undulating surface, blah, 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 blah. And then all the orthopedic surgeons look at, but haddi kya lagta hai? Show me what the bone looks like. And that's where I think CT gives you a great idea. You know how much that bone is irregular, you know how much you're going to scallop into that bone if you do anything. You know, if you're going to get an oats, you have a clear idea of how much of that bone you're going to harvest and take out and how much of the gap you need to fill in. I think you're just much more comfortable with looking at CT when it comes down to bone. So it gives you a better apparent understanding of the underlying bone when it comes to osteochondral lesions. The third thing that happens is impingement. So when we have people who have chronic injuries or chronic ligamentous injuries, they get instability. When they get anterior instability, what ends up happening is obviously you start developing tibiotalar osteophytes or bony proliferation. And that bony proliferation can lead to everything from bony impingement at this point to impinging against the traversing neurovascular structure or the extensor digitorum tendon. So it can impinge upon those anterior structures. The second thing you end up sometimes is with posterior impingement. And then again, you know, most of these people, they do not, it's not like this ostrigonum osteata process grew yesterday and they suddenly develop posterior impingement. It's usually that it's been there for a long time, but now there's underlying ankle instability, and therefore that posterior process of the talus or that ostrigonum will impinge against the posterior structures, producing its impingement symptoms. So what CT allows you to do is to size up sort of how big those impinging osteophytes or bony spurs are. And then you make a decision on how you want to manage them as to whether saying, okay, look, it's a small bony spur, there's a little bit of impingement, let's just put you on stability. It's a small bony spur. I think you have impingement. Why don't we give an injection, reconfirm the diagnosis, get you on some physio and rehab and see how you do. Or we say, no, you've got a big surgical spur, you've got a big spur, you've already failed physio, you failed injections, and perhaps we should now think about doing surgery to remove those bony bumps. And in that case, CT is helpful to tell you exactly how much bony bump you want to remove, which approach you want to take if you're going to do it arthroscopically, how much bone you're going to shave, and getting all that information beforehand. So when it comes to soft tissue injuries with chronic pain, we're going to be looking for three major things. Missed injuries, like I told you about the syndesmotic injuries, osteochondral lesions, and then impingement. Moving to the fourth situation, you have an obvious ankle fracture, and now you have delayed pain. And the question is, you have an obvious ankle fracture with delayed pain. Why would you go ahead and do a CT? So the first thing you obviously want to know is, has this fracture healed, right? So we see plenty of fractures like this lateral process talar fracture, which has not healed, or this fifth metatarsal base fracture, which has not healed. So you can assess the union nicely on a CT in terms of whether a structure is healed or not without considering the overlaps. The second thing is you can assess the union as well as the resultant angulations or changes because of that union. So you are looking here at the extra articular structures. You can see that this distal fibula has healed with this medial malleolus, and you've got this, basically posterior angulation of the distal tibial articular surface. You've got anterior impingement. So it gives you a good sense of, after the union, what are the angulations that have happened? How have structures changed in orientation with each other? from the extra-articular side. And then it also gives you a sense from the intra-articular side that after you've removed hardware, what is the gap in the articular surface, what is impinging against what, where are the, what is gone into which locations. So it gives you a sense of what the structure looks post-union. And given that CT allows you an incredible number of reconstructions, 3D reconstructions, ability to subtract bone that's coming in the way, it can really give you a really nice idea of what the structure is and how the structure has healed. Last but not least, oftentimes we think that, look, it's not worth going back to fix the structure. It's going to be an arthrosis joint. It's going to be terrible. But you want to know that if I'm going to fuse one joint or two joints or three joints, which ones should I fuse? And there CT, although I would favor MR in this case, but CT can give you a sense that, okay, is there subtalar joint involvement or not? So here there's purely tibiotalar joint involvement. There is not much subtalar joint involvement, but there is some posterior impingement in the subtalar joint. Similarly, here you can see the tibiotalar joint is pretty good, but the subtalar joint is irregular in this patient who's post-calcaneal fracture. So it gives you a sense for which joints are involved with osteoarthritis and therefore what kind of fusion you may have to go in for. Impingement and subluxation is another thing that obviously happens commonly post-trauma because bones remodel. So here's somebody who has a lateral process, I think with a calcaneal fracture. There's a bone spur here, and this bony osseous fragment impinges against the anterolateral structures. Here you can see somebody with a calcaneal fracture again, and you can see that there is subfibular potential for subfibular impingement in this patient. And then here's somebody who had a calcaneal fracture, and you can see this bony spur arising posteriorly, causing an element of posterior impingement. So impingement, when you do see it, it can, as we described earlier, be osseous, where two structures are blocking each other. It can be neurovascular if it impinges against a neurovascular structure, and it can be tendinous if it impinges against a tendon. Sometimes we can also look very carefully at the soft tissue structures, and here you can see a patient with a complex injury. And not only that, you can see that the fibular tendon has subluxed out of the retromalleolar groove and moved here along the lateral aspect of the lateral malleolar. So you can assess the soft tissues as well with CT. So if you have an obvious ankle fracture, it's gone into healing, and you have delayed pain, then the questions you're going to ask yourself is this union versus non-union? Whether it's malunited, and if so, is the malunion an extra-articular or intra-articular? Whether there's osteoarthritis or not, if so, which compartments are involved, impingements, and then you can look at soft tissue subluxations. Let's look at the fifth situation here. We have fixation with hardware now. And here again, you have somebody with fixation, hardware, and pain. Here, the key thing, first of all, is to see that, look, was an injury missed? So if we look at this, this is a bimalleolar fracture. This patient has had a lateral plate medial malleolar fixation. But when you look at the axial images, you can see there's a lot of widening of the syndesmosis. Look at a comparison with the opposite side, which is normal. And you can say nobody has addressed the syndesmotic injury here. And that's why this person is not responding well to their current treatment plan. You can assess the union across the actual fixation site. So because you can now use higher KV techniques, you can look at the bone quite nicely adjacent to metal. So here you can see how, despite this hardware is going through, there's no loosening along the hardware, but you can see nice sclerosis along that joint margin. And you know that there has not been any bony union across this joint. And if there has been bony union, you can tell that it involves only 10, 20, 30, 40% of the articular surface. So you know how stable that union is going to be. As opposed to this case here, where you can see there's nice bony union across the tibiotalar joint. So union across the fixation is something that you can tell really nicely on CT, and you're hard pressed to tell on X-rays sometimes because of obliquity, and MR because of magnetic susceptibility artifact can sometimes become a problem. From there, we start to look at the hardware itself and looking at the integration of the hardware into the system. And here you can see, for example, someone who had a lateral plate for a calcaneal fracture. They've got bone graft in here. And you can see that there is sclerosis along this margin of the calcaneum at the interface with the bone graft. So you're pretty clear that this bone graft, even though this is early days, may or may not get integrated over time. And you're going to continue to watch this or follow this closely. Similarly, here you have a patient who has who's had an arthrodesis done. You can see that the arthrodesis has not united at all. And then when we look at it a bit closely, we can see that there's a very subtle lucency that's running along the entire nail over here, and therefore this nail has not really integrated, and that pretty much confirms the fact that there's probably no union across this arthrodesis site, and therefore this nail is actually becoming loose. Another thing we see with loose nails sometimes is you can see that the bone continues to get stressed, so you can develop stress fractures, and that can be an additional cause of pain for somebody who's post-fracture fixation. Sometimes hardware goes into odd locations, and there it can impinge. So here's a little screw that's going into the sinus tarsi. Here's a screw head that's impinging against the navicular. And here's a little plate that's coming up here and creating an element of subfibular impingement. So when it comes to looking at hardware, I think the key things that one wants to focus their attention on is, one is, A, did you miss an injury that this hardware has not addressed? B is there union across that hardware or not? And then C, you start to look at the hardware itself and you talk about its integration, the possibility of bone stress and fractures that happen with the hardware, implant fracture and migration, as well as impingement from the hardware. The last situation I'm going to talk about is the characterization of bony abnormalities. And here, I think one of the things we see oftentimes is you see an X-ray where you see some cortical thickening. You see the MRI, you see cortical thickening with a periosteal reaction. You look again at the MRI images on one of these patients, and I'm showing you 3 different patients now who have presented fairly similarly. You can see that there's a little bit of cortical thickening edema. You can see periosteal and intramedullary edema and a little bit of cortical irregularity. You have another patient here similarly with intramedullary bone marrow edema, a little bit of cortical edema, a little bit of periosteal edema. And you have another patient here with, again, more focal hypointense area in the medullary cavity in the subcortical bone, but plenty of marrow edema and some periosteal edema itself. And it puts us in a bit of a quandary as to what we're dealing with, what is the exact condition that we're dealing with here. But when we do a CT, this one becomes very clear that this is a stress fracture. When you do a CT for this one, you can see very clearly that this is a case of Brody's abscess or osteomyelitis with sequestrum formation in the cortical, in the cortex. And you can see this last one is a pretty classic osteoid osteoma. So, it's very helpful to use CT to further characterize some bone lesions that we see. And I've shown you an example of stress fracture, osteomyelitis, and osteoid osteoma. So in summary, I'd like to say that, what I've tried to do in the last 15, 18 minutes is that CT probably has a role to play in what I see usually in practice, 6 typical situations. If you have an acute injury with no detectable bony injury by X-ray or MRI, a subtle fracture can give you implications in healing and more significant injury. If you have an obvious fracture in the acute setting, then obviously it helps you to confirm, whether your thinking from the X-ray is appropriate or not. Did you miss an additional injury? And then to better characterize or classify that particular injury that you have, that would help you with management. If you have a soft tissue injury with chronic pain, then, missed injuries, OCDs, impingements. If you have an obvious fracture with chronic pain, then we're thinking about the degree of union, osteoarthritis, impingements. If we are doing post-hardware imaging, then obviously, did we miss the injury? How is the healing across the area of the hardware placement? Is there stress? Are there stress changes in the bone? Is there hardware failure? And is there impingement by hardware? And last but not least, on X-ray and MR indeterminate bone lesions, we've shown you how we can see stress fractures, osteomyelitis, and osteoid osteomas. So with that, I'll end my talk. I don't know if you want me to just go ahead with the case. It's only about 5 minutes.
No, I think we'll have the case if you have time later on, if that's okay.
Right.
But thanks, Dr. Aditya. That was, I think, an excellent presentation of all the various varieties of things which you can diagnose on CT scan. Dr. Nikesh, do you have any comments on that?
Yes. So we have we have a few questions from delegates, and should we go ahead with the questions? How many minutes we have, Maninder?
So I think we'll take some of the, we can take a couple of questions, but I think your comments on what you think, what you thought about that, any comments on any of the conditions that are there?
Pardon? I'm not getting.
Dr. Nikesh, do you want to say anything from your side about the lecture? What anything which
it was
found
very informative, Aditya. Thank you so much. And it has cleared so many doubts about many things. like how to assess the union in the presence of implants, the comparison of bilateral situations. I mean, comparison with the opposite side of the CT scan, everything. So it was very informative.
Great.
Aditya, a few delegates have questions. I will be fast.
Yeah.
So, what is the role of weight-bearing CT scan in foot and ankle surgeries? Can you
I don't use it.
Okay.
I've never used it. And but I think that most answers you will get if you use a combination of good weight-bearing radiographs and CT. Obviously, those who have it will find the one or two reasons where it makes a difference. But I don't think it's, if you've spent that much on that machine, then you will find reasons to say there's a use for it. But I personally don't see that there's any major use for it.
Right. And I mean, what we have observed in India, that people who do this CT scan of foot and ankle, they take large cuts, and we miss many of the in between pathologies. So, uh, what are the cuts you suggest? How many millimeter cuts one should take?
So yeah, I mean, so it
taking-
depends a little bit on the scanners that are in the area, but most scanners can do thin section images nowadays. I would say that if you're looking specifically at hardware or you're looking for small findings like osteoid osteomas, aim for 1 millimeter or less in terms of thickness of slices. And if you have hardware, then definitely ask them to do images that use a high KV. That has greater penetration, so you get less streak artifact from that. If you're in bigger cities and have fancier scanners, some people can do some post processing to reduce metal artifact. So that's the other thing that you can request if there is metal in those cases. Those would be the big three things. And also, I think the other thing is you get a lot of images sometimes. So the radiologists don't know what to look at when you're looking. So if you're more specific with your question, then they can tailor the exam to cover just that area, get you really thin sections, get you recons, and do everything with that.
Right. And when to order CT scan in ankle fracture? I mean, all cases or a few selected cases? Because yeah, please.
Like I said, I think it is a question of you as an individual in terms of looking at a case and saying that, this is, like you said, the reasons why to get a CT they've shown in ankle injuries is primarily so for if it's a malleolar injury, then the reason is did you miss a posterior malleolar fracture, because you know that then you've missed a syndesmotic injury, so you should have stabilized the syndesmosis, you shouldn't have. So how confident are you that the syndesmosis is intact or not intact? Then you'll decide that you want to get it. And probably the second reason is, you're not sure if there's intra-articular extension or not. And B, if there is intra-articular extension, you want to know how much of the articular surface is involved and to what extent, because that would do it. So I think those would be the primary questions that I would think of as to why I would want to do a CT.
Yeah, and there are also another last query is how CT and MRI can be complemented to each other while ordering the CT scan or MRI. So in which conditions, like we need only CT, in which condition we need only, or should we order a complementary or combined study?
Yeah, I mean, I think the question, it's usually related to what is your question and how I would say it's related probably a few different things. So one is, what is your question? Two is, what is your faith in your radiologist to answer that question and to say that, listen, this is my question, you decide what the imaging test is, right? And three is, if you don't have that faith in that person, then you say that, okay, this is the question, and what is, in your experience, how do you best answer that? Right. So in your experience, you're more comfortable seeing
it's
that
always a
abnormality
mutual discussion and right.
Correct.
I get it.
Yeah.
Thank you so much.
So I think, Aditya, you answered that question very well, because basically you're right that, we do find that a lot of some of the radiologist reports that we get, especially on ankle MRI, are not what we don't sometimes tend to agree with what is written in the reports. And then there's a quandary of what is your relation with your radiologist. I think that's a really important point of having a good relationship with your radiologist, so that you can rely on him and he can rely on you also, that what you're asking is actually, so I think that's really an important point. Just one question I'd like to ask you, Aditya. You talked about bony impingement. So do you think, let's talk just about bony impingement. Do you think about ankle bony impingement, anterior impingement? CT adds more than an MRI to find out that exact bone impingement that is there, or we can just do with an MRI on its own?
So actually, for impingements, I think again the question is, what do you want to do about the impingement?
Yeah.
So the first step is there impingement or not? And if you look at is there impingement or not, I find the best thing is ultrasound, because there you have the patient in front of you. You say this, he says this is where it hurts when I do this movement. You put the transducer over it. You can see a piece of bone under it. You can see it sticking. You can see it impinging. So that's like the number one way of confirming that there is impingement with imaging. Once you've decided there's impingement, then the question is now, what do you want to do with it? So the advantage that CT has over MR is because of the way that the images are acquired. It is easier to give you a sense of the 3D geometry of that bone. So if you decide that I'm going to shave it off, you know, okay, this is going to be a triangular bump, or this is going to be a rectangular bump, or this is going to be a semicircular bump. So you know what you're shaving off.
Yes.
With an MR, because you only get sagittal, coronal, and axial images, sometimes that 3D anatomy is a little bit more difficult to put into your head.
Okay, great. Thank you so much.